Is this going to be set up so people can talk as I'm talking and jump in, or
If you
'cause
sure.
I'd like that, because I'd like it more discussion oriented if I could, especially um, because I thought it was going to be kind of quick and dirty at the end of it. So, we can take a little bit more time if we'd like to and talk about what we think is important. Nick, where do I find my
Share
button at the bottom?
Bottom middle.
All right.
No.
There.
Nope.
Yeah, double click.
I put it on.
There it goes.
Now, use slideshow. Slideshow. Good job.
All right, so it's again difficult as a psychologist in this heterogeneous group to come up with something that's useful and interesting. But I thought I'd just kind of back up a little bit, and something I've been thinking about is just kind of looking again at opioids, opioid prescribing, and talk a little bit about issues related to efficacy, give you maybe a strategy for doing a risk assessment, and then to just talk briefly about some alternatives to them as well. And it may be, as I said, useful just to kind of go to 30,000 feet again and think about opioids. This is one of my favorite slides when I think about the pain experience. And I start a lot of talks with it because it's a gentle reminder to me and my audience about the complexity of the pain experience, including not only pain, but suffering with pain, because I think they're intimately related, particularly for our patients. But it's also a reminder as you go around the hours on the clock, a reminder of all the different factors that affect the patient's pain experience. The social situation, their history, their health, their use of self-management strategies or lack of use of them. Of course, the nature of their injury or their illness is important. How they perceive their pain is an area that, as a psychologist, I've been particularly interested in. And then I guess today we're going to talk a little bit about medical interventions, in particular opioid treatment. But I guess I want to just for a moment remember that medical interventions are just one piece of the pie that can affect a very complex experience of pain. And within medical interventions, opioids themselves are even a smaller piece of the pie. And remember again that lots of other factors may be important in thinking about and talking about the pain experience. So when I'm not a physician, so I'm not a physician, but I'm often confronted with demand for opioids regardless. But I'm in a better position to say no because I'd be arrested. But I know we're all confronted with the demand and expectations for opioids. And where I run into it, of course, is when my physician colleagues and my medical colleagues are sending patients to me to help screen for risk of misuse and abuse. And when I think about opioids and opioid prescribing, there's really two questions. One is, what's the risk of misuse or abuse? And the other is, as I was talking to Rick Vaglanti a little bit ago, is, are they at risk for misusing or are they appropriate? And those are oftentimes two very different questions. So one of the questions that, when I see patients, to ask myself is, what am I really treating? What am I really evaluating this patient for? As a psychologist, is this pain complaint that I'm hearing about, is this a function of a sensory experience? I guess in the easiest sense, a well-adjusted, adapted individual with a complex regional pain syndrome where everything kind of makes sense physiologically and there's not a lot of overlay? Or is there something else going on? Substance abuse, substance dependence is very common. Most of our patients have a history of illicit drug use. And, most of our patients have mental health comorbidities, depression, I think the literature suggests anywhere from 30 to 60% of our patients have clinical depression. I'm going to ask the guys in the room here, what do you guys think the percentage of our patients that have clinical depression? I think it's higher. I think it's much higher. So in a specialty pain clinic, I would say we're probably closer to 80%. And the literature on PTSD is about 20%. But if we go through and interview our patients, trauma histories are trauma history and chronic pain are almost comorbid experiences. I mean, it is well over 50% of our patients have significant trauma histories. So when, asking ourselves, when we're confronted for the demand from opioids, what are we treating? Are we treating an unrecognized substance abuse problem in terms of self-medicating substance abuse, or am I medicating a mood disorder? Or am I treating with opioids because there's a problem in the system? This patient's poor, they have no access to physical therapy or chiropractic care because of where they live. Likewise, they have a lack of access to behavioral health services. So kind of take a moment and sit back and think for a moment, like, what am I really treating when I'm considering writing for opioids? I think it's important. I think that it's particularly important. This is a JAMA article from 2018. It's particularly important when we look at the opioid literature, which is terrible. This was a study looking at opioids versus non-steroidal anti-inflammatories, 12-month randomized trial for chronic low back pain or osteoarthritis. And the outcomes showed for interference with pain, no difference between NSAIDs and opioids. And strangely enough, non-steroidal anti-inflammatories actually were superior to opioids in this patient population in terms of pain reduction. So we have to ask ourselves, again, kind of going back to that earlier slide, when we think about the pain experience, we go back here, think about the pain experience, we're talking about a medical intervention for pain, but realizing for many of our patients, these other factors are probably playing a critical role, which helps us understand why, in fact, opioids may not be very effective for many of our patients, because the pain experience is a function of non-sensory events. And in fact, if you look at meta-analyses, this is a 2015 meta-analysis, the results on opioids are terrible. We don't really have good evidence that they produce meaningful improvements in chronic pain patients. And the multimodal approaches probably make much more sense. So when we look kind of across the board at patients in general, we find a lack of evidence for opioids. And I'm not here to say that opioids don't work for anyone, but again, going back here, to think for a moment about for which patients are they effective. For patients that have a significant piece of the pie being driven by this, medical interventions, whether they're blocks or stimulators or pumps or opioids, may make sense. But when trauma history, secondary gain issues, depression factors are driving the complaint, it's you're asking a lot of an opioid to change the pain experience. Just like you're asking a lot of a chiropractor or an epidural injection to change the pain experience. It's also complicated by the fact that patients that are on high-dose opioids, this is from a pain center in Knoxville, Tennessee. I believe this is where this came from, but I actually don't remember now. But patients on high-dose opioids actually reporting higher pain severity, worse functioning, worse depression versus patients coming into the clinic without opioids. That being said, patients love their opioid. So there's, despite clinical indicators saying that their pain levels were higher, their functioning was worse, they continue to perceive them as very, very helpful, which makes it, one of the challenges in writing for opioids. If you ask them, how do you feel? I really, really like them. They're really, really helpful, but pain's not changing, neither is function. Again, what are the issues? Well, part of the problem is the squeaky wheel gets the grease with these patients. High-dose opioids are often prescribed to those patients with significant psychopathology. Again, in our population, most of our patients have significant clinical depression, significant histories of substance misuse or illicit drug use. This is a VA study, actually, and said, who's likely to be prescribed an opioid versus an NSAID? And if you have a diagnosis of depression in your chart, you're 8 times more likely to be given an opioid than an NSAID. If you have a personality disorder, you're going to get an opioid. And if you have a history of substance abuse, you're 5 times more likely to be prescribed an opioid than an NSAID. So we've got patients with significant comorbidities, and we're prescribing medications that are likely to not only increase the risk of misuse, but are also likely to result in some difficulties in terms of managing those comorbidities. Okay, what else? So how do physicians make decisions on prescribing opioids? This was a study from a pain center in Atlanta, and they looked at the best predictors of who is prescribed opioids coming into a pain center. And what they found was the patient's level of pain was not predictive of who got an opioid, who didn't. The physical exam findings did not predict who got prescribed an opioid. Neither did demographic variables or duration of pain. Who got an opioid was basically who made a lot of noise. Who acted, acting out earns you an opioid. So pain behaviors, distress, suffering were the best predictors of who prescribed opioids. When you ask physicians about who's at risk for misuse, in this particular study, physicians' judgments estimated about 14% of the patients were misusing opioid medications. When they actually looked at that patient population with urine drug screens, they found 50% of the patients were positive for illicit drugs, and about 9% of them were negative for prescribed opioids. So we just don't do a very good job. You can't tell by looking. So I'm going to change gears here a little bit and maybe give you guys a tool or a brief discussion about some various tools that may be helpful in evaluating and assessing for opioid risk. This actually was from the Knoxville, Tennessee Pain Center. They looked at 3 different commonly used opioid screening measures, as well as a clinical interview by a psychologist in their center, and looked at the ability to predict misuse and abuse in their patient population. And the clinical interview was pretty typical by the psychologist. They assessed for pain. They looked at for mental health problems, depression, anxiety, PTSD, common factors. Did a substance misuse and abuse history, social history, looking at trauma, other stressors in their lives. And then based on that intake interview, gave the physician in the pain center some estimate of low, medium, or high risk for misuse and abuse. And we can, at some point, if you'd like to, we can talk about what some of those interview factors might be. The other tool they looked at is the opioid risk tool. Is anyone familiar with the ORT? Does anyone use that? Yeah, you have, okay. It's a 5-item scale. It's typically completed by providers, although I looked at one paper and they talked about patients completing it, but it seemed pretty odd for a patient to complete it. But they basically are looking at family history and personal history of misuse, abuse and abuse of drugs and illegal drugs. We look at age and gender, look at trauma history, and then just a general kind of measure of does this person have some significant psychological comorbidities. So they looked at the ORT, which is very, very quick and easy to do, commonly used. They looked at the DIAR, which is a measure that I actually have never used. I've seen it, but I've actually never used it. It is completed by providers as well. And in the DIAR, you get a chance to rate the severity of various symptoms. DIAR stands for D is for diagnosis, and basically you rate the intensity of, or the veracity of symptoms. So, this is a benign condition with minimal objective findings, no definitive medical diagnosis like fibromyalgia or nonspecific back pain. And at the other end, under diagnosis, it might be something like with objective findings like advanced peripheral neuropathy or spinal stenosis. You look at intractability of the symptoms, saying, has this patient been fully engaged in treatment, but hasn't responded well, or have they not tried much, or the patient wasn't very engaged, the patient was very passive in their approach. Then they look at, various risk factors. And again, psychological ones, of course, are, at one extreme is severe personality dysfunction, antisocial personality, borderline personality, significant affective disorder. And at the other end, individuals that have, no history of mental health problems, functioning well engaged with their healthcare system. Then we look at chemical health, and again, that's just looking at illicit drug use versus no illicit drug use, and a little bit on is this a person that's a chemical coper? Do they tend to use alcohol or drugs or even cigarettes to manage stress? Reliability, do they show up for appointments? Are they a lot of no-shows? Social support, important. Life in chaos. Are they homeless? We see patients, that are at the Bartlett Center, or they're living in, a chaotic home environment, or close family, social relationships, good ties to the community. And then, one of the other things that they look at, which I think is really interesting, is, efficacy score. Does anything work? Or everything we tried made me worse or didn't help. I saw a patient just a little bit ago that had, epidural injection, 5 months ago, and the pain is present still at the site of that epidural injection, and it's gradually worsened over time. Or do they have responses that make sense? Things that should help you do in fact help you. So that's the DIAR, and again, you get a cutoff score, and again, you get a rating of high, low, medium risk. And then the measure that I'm most familiar with is the SOAP, and I can't remember what the acronym for that. It's Survey of Opioid Assessment for Patients with Pain, or something like that. One of the reasons I like that is that it's patient administered, and it's also a little more subtle in terms of its item content. So they'll ask about mood swings. They'll ask about tension in the home. They may ask, have you taken more medications than indicated? But they'll also ask, and they'll ask about craving, but they'll ask about things, do you feel bored? So it's a more empirically derived items that are associated with risk, but they're not so obvious in terms of their item content. So it's a little harder, I think, for patients to fake good on this inventory. And again, it gives you a cutoff score of high versus not elevated risk. So in this particular study, all the patients got all the measures. They all got the interview and they got all 3 measures, and they were kind of looking at which works better. And as you can see that with this is kind of an overlap in terms of the agreement of risk. And what I want you to kind of appreciate for a moment is that, that these measures seem to be assessing risk differently. Clinical interview and the SOAP were pretty close in terms of their overlap in terms of identifying similar patients that are at risk, but the Dyer and the ORT much less similar. So they seem to be looking and identifying different patients, which may be a function again of the nature of the item content. So this is what they found. So they actually looked at patients that were discharged for aberrant use. And type 1 discontinued patients were patients that basically had failed urine drug screens, essentially. Type 2 discontinued were patients that were basically non-compliant, weren't showing up for appointments, was one of the examples. Frequently missed appointments were so kind of more of a subtle measure of non-compliance. And what they found on the clinical interview in terms of the sensitivity was 0.76, which means, you know, for those patients, 76% of the patients that were at risk were identified at risk. So very, very good sensitivity. That, you know, 3/4 of the patients that abused were correctly identified in the clinical interview as being at high risk. The SOAP was even better at about 82% at high risk. The ORT, less than half, and the Dyer only identified about 9% of the patients that went on to abuse drugs. And in type 1, I think you can see the numbers are generally much better for type 1 versus type 2 in terms of non-compliance. And when you combine the SOAP and the clinical interview together, you had a sensitivity of 90%. So 9 out of 10 patients, 90% of the patients that were described as elevated risk at intake were correctly identified as later going on to abuse and misuse drugs. So as I said, I mean, I think the advantage of the ORT is that it's quicker. The advantage of the SOAP, I think, is that it's better. I don't, as I said, I'm not that familiar with the Dyer. Based on this data, I'm not too impressed with it. Although I like the item content as I went through it and talked through it with you guys today and looked again. I like what they're thinking about, but I don't think they're clearly not identifying people at risk using that scale, although the content seems to make sense. So one approach is to, you know, identify people at risk and then make some decisions on prescribing versus non-prescribing. I just want to take just a moment, remind everybody in terms of alternate care that there's very good evidence out there that patients, especially if they've been on high-dose opiate for a significant period of time, actually do better. Now, I'm not sure we clearly understand all the reasons why, and there's some options related to central sensitization of the pain experience. But this was a study of 23 patients that were on high-dose opioid who voluntarily elected to detox. So granted, that's a little different patient population. They didn't have an issue of diversion or abuse or overuse, but they went through a detox, and they detoxed them one of two different ways. One was using ibuprofen, and the other was using Suboxone. So they had a gradual wean off of everything, and eventually wean them off of buprenorphine. And 21 of the 23 patients reported improvements in pain following pain reduction. The average reduction was over a 50% reduction. I mean, we would call that a clinically significant improvement by taking them off an opioid. And so I think that's kind of an important thing to, as we think about medication management, sometimes not only is less more, but doing nothing can be more. Finally, just for a moment to kind of think again about another approach rather than using opioids, and that's writing a behavioral prescription. This was a little news article where this was in Spain, where patients were given general advice to exercise versus getting a prescription from a medical provider. And what they found is that by getting that piece of paper, that prescription, patients were much more physically active than those who hadn't. And I really like that idea, and it's something that I'm trying to do in my practice as well, rather than just telling patients to do some things, to write it down on a little note card, on a little something that here is your prescription, here's your written orders of something I want you to do. Patients, I think, are used to getting that, and they're used to getting a piece of paper with some drugs on it. But my suggestion is that we can write behavioral prescriptions as well, and they can be as simple as asking people to walk 5 minutes a day, or listen to a relaxation CD, or to practice stretching twice a day, or for our patients who are pretty depressed and pretty isolated, to ask them to just engage in a pleasurable activity once a day for a few minutes, to plan and engage in an activity, but to write it as a script. And there's some evidence that physician-directed recommendations that are lifestyle related can be effective. This was a project done that was presented at American Pain Society a number of years ago, where they looked at physician-directed lifestyle related to activity, exercise, yoga, tai chi, stress reduction, meditation, breathing exercise, diet control. That combination of directed lifestyle resulted in improved pain tolerance, reduced hyperalgesia, reduced psychological distress. So that's my kind of overview of opioids and an alternative to opioids. I don't know if anyone has any thoughts, questions, or want to chat about it a little bit. Has anyone ever written a behavioral script before? What was that like for you?
I think as PTs, all our prescriptions are behavioral prescriptions.
Of course, yeah. That makes it easy, yeah.
Yeah.
What about as physician providers? Anyone ever write a behavioral script? How did patients respond to that? Greg?
It worked. I don't know. I mean, I don't know that I could really speak to how much better it works rather than just telling them they need to and doing it, but it seemed to. It seemed to help. I wrote a prescription for a lady to start going back to church, and
Cool.
she did. And it's kind of nice. It definitely had a positive impact.
I think that's a really cool thing to do. You get it, you put it on your refrigerator, you have something that this is doctor's orders. I mean, again, it's taking advantage of the power of, particularly for physicians, very, very powerful people with great authority, and that prescription pad, I think, carries a lot of weight. Anyone else do any opioid screening, or risk screening, in terms of experience with those measures?
Sorry, I have one quick question. So when there was a study about, sorry, I gotta look at my note. So the detox program with ibuprofen, when you do that, wasn't there like a side effect, or like, I feel like there will be more problem with now like ibuprofen addiction.
Ibuprofen addiction?
I don't know, like I just see my stepdad taking, like he just popping pills all the time whenever he has pain, and that's ibuprofen. So I was just wondering if that's causing any other problems.
I'll be honest, I didn't review the study before I put this together, so I was pulling some other slides together, so I don't remember the particulars of how ibuprofen was prescribed. just that they had a group of patients that were given ibuprofen for pain, and some of the patients that were given Suboxone for pain, and they basically, weaned them off their opioids and gave them something else, and then eventually weaned them off of those things. So I'm not familiar with, problems with in that study with ibuprofen being a problem. That is responsive to your question.
To your, just if I could answer that. And so I had a question too, Richard, about that study, but again, not having the details makes it a little bit difficult, but I think there's no dependency issue with the NSAID. You worry about sort of if you risk stratify patients at a maybe higher risk with respect to, let's say, kidney disease, or they had a history of maybe they had ulcer disease because of maybe taking too much aspirin, or NSAID. That, I think you have to pick the right patient, for if that is a management technique to try to get a person off of an opioid and you're going to use an NSAID, I think you got to make sure that's the right kind of person for the NSAID, because it does have liability because it can affect blood pressure medication, and you can lose blood pressure control. It can affect kidney function. You have stomach issues with respect to irritation, ulcer, bleeding, but dependency, obviously not. But I was really intrigued by that technique, because for the right patient set, that makes a lot of sense.
I'm gonna turn this. I'm gonna ask Dr. Vagilanti, because I know he has weaned lots of patients, in lots of different ways, and I don't know if he has some thoughts about strategies for weaning that have been more successful versus less successful in terms of getting people off of opioids with a good outcome.
Well, the biggest thing I can tell you is there's no set time period. And so the patient often thinks that when you give them a prescription for weaning purposes, that's the end of it and you'll never see them again. If you want to do it correctly, that's not the way to do it. You have to interact with them and do a lot of education about why you're doing it, and that I can't count how many times I've told patients, you will be off your pain medication and your pain will not have changed. And they look at me like, they can't possibly believe that. But it happens almost every time, unless there's significant psychological reasons for them to crave that medication. And as Dr. Gross said, primarily anxiety and depression and personality disorder. So we had an interesting case the other day of a 47-year-old woman who transferred care here because the physician who was writing her opioids no longer took her insurance. And so the patient was incredibly demanding from the very first interaction with the clinic via telephone, and had subsequently canceled 2 appointments. And we had gone out of our way and actually gone outside of our policy to arrange for Dr. Gross to see the person in the morning for an opioid risk evaluation, and then for me to see the patient in the afternoon. So I had the benefit of talking to Dr. Gross before seeing the patient, and he gave me some touch points about his interview with her. And we sort of agreed at that time, without delving too deeply into it with each other, that she was probably a personality disorder. So armed with that, I walk into the room, and the first thing she says is, "Your medical assistant broke my arm with the blood pressure cuff. The blood pressure cuff had pumped up more tightly than I've ever experienced in my life, and my arm is hurting, and I don't know if it'll ever recover." And so I at this point remained calm. It was too early not to remain calm. And I said, "Well, to be fair, this medical assistant doesn't really control how that machine inflates or deflates. It's based upon feedback of whether you hold still or what the readings are, to no avail. So at this point, I start to get the feeling of where this is headed. And I asked the patient her age. Now, I'd been prompted that this was an area of sensitivity. And so I said, "How old are you, ma'am?" "I don't count my age. Age is just a number. It doesn't mean anything." I said, "Well then, do you agree or disagree that your birth date was such and such a date?" And she said the same story over again, only a little bit louder. And I said, "I'm just trying to verify that you are actually who you are. And if you think about it, what do we ask everyone? What's your name? What's your date of birth?" And that's to keep people who have the same name from getting mixed up. So she was irate at this point, and her husband was in the room, and the husband is an integral part of this behavior. So the bottom line here, without going into the final outcome, which, by the way, wasn't good, is that this patient had been on opioids for a long time by a local pain physician who did not have the luxury that I have of having all these people around me to bounce things off of. And so it was easier for that individual to maintain her medication, which, by the way, was a reasonable dose. And after further discussion, Dr. Gross and I both agreed that this was not harmful, but it was likely not helpful. But there was no way I was going to tell this person, "I'm taking you off your pain medicine," because we had no rapport. And so usually what I'll do is allow these patients to come in, and over time, as they realize that we're not there to hurt them, or at some indeterminate time, then say, "Look, you really should consider this, that, or the other thing," and then begin the weaning process. So
That's it.
you just have to take a deep breath and you know, figure out where you're going at the outset and relative time frame.
That's a really good example of that first slide of, what are we really treating here? And I think Rick and I both recognize, we know what we're treating here. I mean, we're not treating pain with that low dose opioid. So as I said to him, I said, well, she's at low risk for misusing them, but they're not really indicated. And so I think what he said was, okay, we'll prescribe this, hopefully have a therapeutic relationship, and then be able to make some inroads at some point down the road, because clearly, her pain complaint is being driven by many, many other factors than purely somatic injury.
So let me throw this out there as an educational point for all of you and just yell out your answers. So had I tried to change the dosage that day, I would have become the worst doctor in the world, and the previous doctor would have been the person who truly understands me and gets me. And in addition, I said, well, how long have you had this problem? And she said, from birth. So what do you think the personality disorder is here? And it's a mix, but what predominant one do you think it is?
Histrionic.
Yeah.
Borderline.
Yeah, definitely. So you're right. These don't usually travel alone. They travel in groups. But this idea of you don't know anything, and the guy who basically, in parentheses, did everything I said is a great guy, is typical of a borderline. So if you walk in the room and they've never met you and they think you walk on water, back out of the room.
So, I think with this patient, long term, we're not doing any harm. Throwing her out would have been really noisy, and she would have bounced who knows where. we've got now established a relationship with
Well,
her.
not so fast.
Really? Tell me more.
She's out.
Is she?
Yeah, so the bottom line.
Oh!
Bottom line is Dr. Gross is the best, most understanding caregiver in the world. I am the devil incarnate, and she called everyone from I don't know who, and I expect her to call the CEO of the health system. Her husband has a mid-level job here at the university, but acts as if he's the administrative assistant to the president of the university. And unfortunately, this game has been played so often here within the system that this group is well known. So she did not want to see me again. And we have a policy that if you fire one, you fire all. And no one, believe me, many practitioners in the clinic that day heard this woman and understood that they were to get nowhere near her. And so she will not be back, unfortunately.
Dr. Peters had a question. I wanted to make sure we got to it.
I was just curious, and this lady that Rick described doesn't fit this, but I was curious. Pseudo addiction is something that I'm convinced that I see from time to time. People who kind of exhibit this addictive behavior, misuse behavior, as a result of pain that is uncontrolled. And I always wonder in the studies how you would ever tease that out, or how even just in clinical practice, if you have somebody that comes in and you ask them, have you ever taken somebody else's medication? And they say, well, yeah, my mom had some hydrocodone that was left over from when she had her knee replaced or something. And I've thrown my back out, a dozen times in my life, and I work in the coal mines, and I've been taking, a couple of the pills that she had left over. Is that really a person? Obviously, at least in my mind, just kind of logically, is that the same level of risk or diversion or misuse as somebody who's buying them off of a friend of his, or buying them off the street, or that sort of thing? And I don't really have a good grasp myself as to how do you triage those people when you're making referrals to pain management, or trying to make trying to quantify their risk before you send them on, or you try to treat them yourself.
I'm going to let Rick answer the pseudo addiction thing, but I want to say just one thing. I agree with you. Those are different people. The person that said, my husband and I have the same prescription, or my leftover, and I took it once or twice. Clearly less risk of misuse or abuse than the other person. But there is something there in that they're taking a non-prescribed medicine that they shouldn't do. So it's something that you want to be aware of, and you want to educate them on, because there's misuse, and then there is that real psychopathology, and that person is misusing that medicine. So it's fair to say that that's misuse, but usually that patient they tell you it, and then you say, okay,
and then sometimes I wonder too, right? So it is technically misuse, but when you diagnose somebody with opiate use disorder or opiate use in an EMR, I always wonder about the gravity of that. When you're really, what is it that we are really diagnosing with those people? Because that's a badge that person carry. That's all of us. Certainly maybe not all of us, but I can say myself, when I see somebody and they have the diagnosis, they carry the diagnosis of opiate misuse, certain things become off the, certain things are just off the table, at least in my mind at first, before I've ever even really met them. And I don't know, are we really doing a disservice by doing that. You know, when we diagnose somebody that took, you know, like I said, it's just, I don't know, in my mind, it's not as algorithmic as we would prefer it to be when you're trying to assess use and then how to be good stewards of these medicines, because these medicines carry with them such an extraordinarily high level of responsibility. So
I would agree with you. And I think there's a difference between giving someone a diagnosis of an opioid use disorder versus saying this person has a history of, you know, in the past they've misused medications. And, you know, and that's, and you know, as a provider, you should know that they, you know, I use this medicines, I do this, because you need, if you're going to write prescriptions, you need to be able to say that no. And you can't do that anymore. So there is a difference between misuse and an opioid use disorder. And I'll kick it to Rick a little bit about the pseudo addiction. I know people have talked about it in the area of pain a lot, and there's been a lot of go around and controversy about that whole term.
Yeah, I think what you describe is under treatment of pain with opioids. And that's pseudo addiction. Rick's right about that. Nobody really knows whether they believe or disbelieve that there is such a thing, but certainly there is under treatment. So what I do most of the time is, if an individual like that says, I took 2 of my wife's hydrocodone, 1 in the morning and 1 at night, and it was life-changing, there's nothing wrong with giving them a legitimate prescription and signing them up under whatever agreement you use and tell them you'll see them back in a month and reassess. And if they come back and say, you know, thank you, that was really great, or if they start out, and I've had this happen numerous times, you know, if I just had 2 hydrocodone, I would be, you know, in nirvana. And then they come back and say, well, that was good, but a 3rd pill would really ice the cake for me. That's a bad sign. And so if you set the limits early on that you're going to treat them appropriately as long as they act appropriately, that's one thing. The other thing is clinical suspicion. I got called many years ago by a very fine family practitioner who said, I need your help. I have a woman in my office who's been bothering my office staff for the last 2 days since she was in the ER. And I said, well, tell me a little bit about it. Well, she fell and she broke her fibula and she's in a cast, and I gave her tramadol and she keeps calling for more meds. And I said, okay, so how much tramadol? She said 50 milligrams. Perfect. How many times a day? Once. I think I know what's wrong here. So, you know, you have to be reasonable about that. And unfortunately, the sum of this is, with so many physicians dropping patients for opioids, whether on reasonable doses or unreasonable doses, this will get worse for a period of time before it levels off.
I think Dr. Peters brought up a really, really good point there, which I would even extend to a different story of the leave the patients out of it and just, like, you know, let's go kumbaya, and you close your eyes, and everybody here who's a healthcare professional of some sort, if you hurt your back cutting the grass, whatever you're doing that for when it's 40 out tomorrow, there's a hydrocodone pill sitting in your house, and you already tried an ibuprofen and a Tylenol, it didn't work, and it's sitting there. Are you going to take it? Not for the cough, that's codeine. And then the follow-up question, not knowing that cough was coming, would be, okay, and then like a month later, if you go for your annual physical and you fill out a form, and are you going to circle that you did? And it's really not that big of a deal. Man, we need opioids around here.
Only if I know I'm going to be urine drug screened.
That's a whole nother level. The point I tried to make is just building off what Dr. Peters said and Dr. Valiani, be like, you know, not everything's an issue. People call poison centers for PEZs all the time. They also call for Tylenol overdose all the time. You know, that's on us to distinguish, but there is that reminder that, you know what, people call for Pez. It's not always an issue, but boy, we have to be Sherlock to figure out when it is. So
Yeah, I mean, people can take, I just saw a 75-year-old woman who's been on hydrocodone 5 milligrams 4 times a day for years. She came back for a reevaluation to kind of check in to make sure everything is fine psychologically, and we do that periodically. We don't assume, that risk is stable, that risk can change. And she, she's living independently. She likes walking on the rail trail for hours at a time. This is a lady. I am not worried about her hydrocodone use. And I said, well, how does it? She goes, oh, it takes about a half hour to kick in, and then it helps me, and when I get up and I go. No harm, no foul. She's, that's again thinking about that earlier slide when you think about, what is driving that complaint of pain. There's not any psychological factors that are contributing to her pain/suffering. And she was having a response that, again, talking about Rick, had a response that made sense. She takes this, she's on a stable dose, she does great. As opposed to everything I've ever taken has made me worse, or I've had an allergic reaction to.
This would apply to our physical therapy colleagues too in the acute setting. There's nothing wrong with medicating a patient prior to PT if that facilitates accomplishing what your goals are. And I can't count the number of physicians who panic that that's an unreasonable thing. But, if someone says, if I need a hydrocodone before therapy, and then I'm really sore and I need one after therapy, and then I'm good to go, perfectly reasonable, okay? If someone medicates them to the point where they can't participate, that's completely different.
Right.
But I've had years ago when we were at the rehab hospital, there were a few patients who would go to therapy and do nothing because of the pain. And of course, even then there were limitations that if you weren't interactive, you couldn't stay in the rehab hospital. And so we'd often come in and say, okay, what do you think it would take for you to participate? And I don't remember anyone saying that it would take 90 of oxycodone 5 times a day to participate in 2 hours of therapy a day.
Yeah, I think you raise a very good point there. We talk about looking at co-managing along with appropriate opioids and, the non-pharmacologic approaches and the cognitively informed treatment and all of that together.
So one of the things I think you're raising a good point, Dr. Vagliante. One of the things that I encountered in the clinic was a patient who was a VA and was referred to me for back pain. And I was examining that patient. It turned out that he had, pain in his lower back, and sometimes he feels it in his buttock. And I got him to agree that we're going to be doing exercises. So we started the exercise program, and everything was fine. He left fine, but before he comes back, I got a call from his physician telling me that whatever exercising you're giving that patient, just try to change it, or just give him whatever passive modality you have, like e-stim or whatever, because if he doesn't do the physical therapy, I'm going to put him on opioids. So in that situation, when the patient came back, I told him the story, and he said, yeah, the exercises weren't very helpful, and I was in pain for about 3 days after you did the exercises. So basically, I started to put the e-stim and heat on him, which I believe are going to affect the pain for about an hour or hour and a half, but then they're not, the effect doesn't last that long. But what was effective for him is that it turned out, as I got to know him, if I let him lay down on tents and complain, he was getting so better. I mean, he feels so good after complaining about, I mean, Vietnam War, CIA, his physician telling him to quit smoking, and literally he would come into the clinic with the smoke smell all over the place. And it turned out that this was very effective for him, more than exercises. And he was saying, I'm getting better, I don't have pain anymore. He was getting along. And so this has been my experience with some of these people.
Well, two things. Number one is you took Dr. Gross's job away from him. And number two, credit to you that some physical therapists and others are such purists that they would have just waved their hand and said, get out of my clinic. You know, this is not what I trained for. But you made him better. That's the goal, isn't it?
Yep. I mean, I was happy. I mean, I wasn't unintentional. I was, you know.
Right. But, you know, that's what I'm saying. Some of your colleagues would say, you know, there's no way this is going to work, and would set him up to fail. And it's, you know, it was good that you listened to the primary care guy because he got it right. So no harm, no foul there, you know, and it just cost you a few electrons, and so what?
So that's the one thing. I had a question. We do screen patients referred to us if they have any psychosocial issues. As far as psychosocial interventions that we do is pain education.
Okay.
Anything more than that, we tend to refer. Now, I like this stratification tool, the SOAP.
Yes.
That stratifies. Do we do this SOAP at the primary care level that we are at? Do I do it with every patient? Or do I expect those patients who refer to me to have an alert that say, you know,
There's something better. Wouldn't there be something better for him?
For you, I would not recommend the SOAP because that's really looking at opioid risk. You're a physiotherapist, is that correct?
Yes.
I mean, I think when you said what we do is education, and I think education is hugely powerful and important, but you gave a really nice example of that it's not just about facts. It's about, you know, patients feel like they're being listened to, they're cared about, they're reassured.
Exactly.
And reassured, and that's very, very powerful. So, you know, years ago, physical therapists were looking at, and you're too young to remember the old back schools, but they used to have back schools. And the back schools were never really that effective, just giving people education about your back and now you're fine. Because it wasn't a knowledge deficit that was the issue. The issue is that patients need to feel safe, that this is not dangerous. Pain is scary, it's frustrating, it's mysterious, and you as a physiotherapist explaining the pain, you're explaining the pain, but it's really not a knowledge issue, it's a reassurance issue. Exactly. I get it, I understand, it's not dangerous. So if you were going to look at a measure for you, I would look at the pain catastrophizing scale. Pain catastrophizing scale is that just will tell you so much about what's going on and how they're thinking about their pain.
Yep, we do that. We do the start back tool as well.
The what tool?
The start back tool.
Okay.
The start back tool. It stratifies whether the person is at high risk of developing poor treatment outcome, which does the same job as the pain catastrophizing scale. But I was just wondering if this is something we mean, the soap is something.
I don't think the soap is going to tell you anything useful. I think that the tool you talked about and the PCS are much more powerful tools. Or that, or the Tampa scale of kinesiophobia is also, from a physical therapy perspective, the fear of harm associated with movement.
Right.
And you teach to the test, of course.
Right.
Great. So guys, we're at time. I really love the discussion that went on today. I'm sorry our video shut off. We're still here. I don't know what happened. Everybody have a wonderful Thanksgiving. Our next session is December 5th, and we will send out all of the stuff from today. And thank you so much, Dr. Gross, for the didactic. It was great. And thank you, Dr. Vaglienti and Dr. Gross, for the case discussion. That was great, too. Everybody have a wonderful week.
All right.
No problem.
Thanks. Bye-bye.
Thank you, everybody.